Good morning, everybody. Welcome to New York on this nice Wednesday morning. We're thrilled to have you back. We have a very interesting case for you, and this is the 11th case in our series so far. And Dr. Dangus is running a little late. He will be here. He had to take care of a patient, and so I'm going to get started with our introductions. In the cath lab today, we're doing a adult congenital heart disease patient, and Dr. Wiley will be presenting that, but we have a lot of friends here to help us with this particular case. So first, I'd like to introduce to my right Dr. Daniel Grunsteiner from the University of Minnesota. He's the head of pediatric intervention there. He's kind enough to come here and talk to us and moderate this case from while we're doing it, as well as give you guys a great lecture on how to manage adult congenital heart disease, mostly ASD and PFOs. Also, we're also very fortunate to have Dr. Greg Fisher, the chief of cardiac anesthesia, who's here to help us with the anesthesia protocol for this particular patient. And also very fortunate to have Dr. Martin Goldman, who's our chief of echocardiography and imaging here at the Cardiovascular Institute at Mount Sinai, and he's also going to help us with all the TE imaging that we need. Now, the other team that you're very familiar with, who you've met 11 times this year, Dr. Jose Wiley, our Associate Director of Endovascular Intervention, Ray Lascano, our Interventional Nurse Practitioner, Dr. Brookheim, our Interventional Fellow, Ricky and Liz, our nurse and our tech, who've been here for every one of these cases. So without further ado, we're going to get started, and Dr. Dangus will join as soon as he comes in. So because of lack of time, I want to get started. Jose, can you present the case?
Sure. Let's put the slide up. Well, good morning, everyone. This case will be a 60-year-old gentleman with a history of a sick sinus syndrome, status post permanent pacemaker implantation, hypertension, who had a remote transient ischemic attack followed by a recent cerebrovascular accident, which was thrombolyzed with full neurologic recovery. As part of his workup, he had a transesophageal echocardiogram with an agitated saline contrast study showing a patent foraminal valley with large shunt and a large atrial septal aneurysm.
So other parts of his workup was he had a Holter monitor as well as an event monitor for atrial fibrillation. He had an echocardiogram done at the outside hospital. He also had carotid duplex workup that was done, all of which was negative. So, and he also had a full coagulation profile to make sure he wasn't hypercoagulable or had any rheumatologic disease. So he has been fully worked up, and the cause of the CVA was attributed possibly to this. So at this stage, I'm going to ask Dr. Goldman to go ahead and describe the TE findings here before we get started. Marty, can you put the TE up, guys? You're not up yet. They're going to put it up now.
So this is,
Can you see the TE or no?
the catheter is actually across the PFO. Went across quite easily.
You can see it now, Marty.
There's an interatrial septal aneurysm that you could see over here, and that every time the person breathes, he's obviously intubated now, the interatrial septum goes into the left atrium, and therefore separating out the patent foramen ovale, the primum, the septum primum from the secundum. So this is a virtual flap that gets separated every time he breathes. There's a catheter across it, and you can see the flow. What's interesting is if you look at that same thing by 3D, 3D color will show it. If you look at the 3D, and we're looking from the left atrium, and you can actually sort of see the slit-like structure, which is the patent foramen ovale. And you can see the interatrial septum in the far field. Every time that lifts off, with every respiration, it separates it. So this is acting like an atrial septal defect. With every time he takes a deep breath, that's going to separate.
So, Marty, what are the other TE parameters that you look for in this, as far as shunt size and other things, just to go over with the audience on what are the other things that you need to look for?
Well, I think that this is at 75 degrees, so this is sort of a bicaval view. So you localize it. We're pointing over here. This is the superior vena cava. This is the right atrial appendage down here, and this is the inferior vena cava here. So you're actually similar to an ASD. Actually, you want to look at the rims. This is the rim towards the SVC, the rim towards the inferior vena cava. and the mobility. I think the presence of intra-atrial septal aneurysm in the bowing makes it a little bit more challenging. I think that this is a pretty good view. You can use the biplane view, again, also to help locate intra-atrial septum as you're going transseptal. And if you can see on this side, you can actually see the catheter as it's going across. You can actually see the tenting occurring, which is helpful in directing it to a safe location as you cross transseptally.
Well, thanks again for that. So now we're going to get started and show you what we've done so far. So what we did here was we went ahead, and what we normally do here at Sinai is to go ahead and get an arterial and a venous access once we know. The arterial access is just to monitor pressures, really taught to us by Dr. Grunsteiner, just to really watch the pressures, and he'll explain his logic on that. The second thing we do here is we have a 5 French venous access, a 4 French arterial access. Then I just want to show you what we did. Scene minus, please. So what we did, go 3 times, scene minus. So what we did is under, minus, one more. One more minus, please. One more minus, please. Thank you. So what we did here was we took a JR4 catheter along with a J wire, and we actually were able to steer it through the septum with Dr. Goldman's guidance. Well, what we were able to do is actually see the wire hit the septum and then pop right through, and then under TE guidance we were able to steer it into the left upper pulmonary vein. Go plus, please. So you can see here the important part here is that you want to make sure that that particular wire is far out into the pulmonary vein so that to give you enough support. Next, please. Then what we did here was we went with a JR4 catheter, which is the catheter we use. You can use a multi-purpose, or I know that you also use a
Wedge catheter.
A wedge catheter in order to do this. And the most important thing that Dr. Grunstein has taught us really is to get it way out into the left pulmonary vein to give you enough support. Next, please. Then we went ahead making sure that there's no bubbles or air, by making sure we suck back, get enough blood. And then we went in and put an Amplat super stiff with a 3 centimeter soft tip into the left upper pulmonary vein, and that's where we are. Now I'm just going to have Dan make some comments here before we go ahead and get started.
Yeah, I think very nicely shown so far by the echocardiography, and these are great images looking at the steps. One of the comments I would make is I think this is one of the more clear-cut cases of a patient who's got multiple risk factors for stroke recurrence. The large atrial septal aneurysm, the large shunt by bubble study, these, as we'll get a chance to talk about later in the lecture, are really some of the hallmarks of a patient who's at higher risk for a further neurologic event. I agree. I think that having the good wire purchase deep into the pulmonary vein is something that a lot of operators are not comfortable with just because of previous teachings, that this is not something that we do. We have to worry about the damage to the pulmonary veins. My background in dealing with patients far smaller than this is that we're willing in congenital patients to put catheters and wires very deep into the pulmonary veins and have not seen significant issues with very long-term follow-up. So I agree. I think having the good stable wire position will help you guide your larger sheath and your device later on.
Well, thank you. And so what we've done here is we've gone ahead and given 5,000 units of heparin. We did it on a waist-based protocol. And I want to make sure that you guys understand that the anticoagulation is extremely important. Our ACT is 290. And now we discussed this earlier. I'm going to let Dan explain to you what our thought process is about balloon sizing this prior to doing it. Dan, you want to just talk a little bit about that?
Yeah, this is not something that, again, that every operator will do. I think there are some advantages to putting a balloon in this. Certainly if this were a true secundum atrial septal defect, the majority of operators would go ahead and place a sizing balloon to help determine the size of the device. In this case, I think it's less of an issue of trying to determine the size of the device initially, but more looking at the morphology of this defect. So Dr. Goldman's beautifully shown that this is a flap-like structure that's popping open and closed. The question is whether this has a long tunnel aspect to it when you put a balloon in, or if everything is just going to flop away. If there's evidence that this is a long tunnel, I think putting a cribiform device for this PFO, although that's an off-label use, would be the choice that I would make. If, as we inflate the balloon, as Dr. Krishnan inflates the balloon, if it looks more like this is a secundum type of defect, I would advocate for using an atrial septal occluder device.
So now what I'm going to do is walk the vein out, which I've done. And now we're going to make a little bit of a nick here in order to be able to get the balloon in. We're going to go sheathless with the balloon. And part of sizing it with the balloon is going to help us to determine what size device we use. And it's also going to help us to decide what size sheet we need. So it's a multiple process here that we're doing. So obviously Dr. Wiley here is going to load it on. And once he loads it on, I'm going to make a little nick before the balloon gets here. And then take the balloon up and use Dr. Goldman's expertise to know when we're across that the actual defect in the septum. So now I'm just going to make a little bit of a nick. So this goes in rather smooth, and without cutting the balloon, obviously.
So the changes over time in terms of how to determine the size of a device to use. If we were going into this knowing this was truly a secundum atrial septal defect, the current recommendations are to slowly inflate this balloon under transesophageal echo guidance with color Doppler flow to see where there's cessation of flow. It used to be when we started doing these that we would just inflate these balloons as much as we possibly could to see a good waist on the balloon and determine sizing by that. We've gone away from that because of the concerns of late erosions from these devices. In this case, Dr. Christian is going to go ahead and inflate this without the color flow initially, just to see what the shape of the balloon looks like.
So now you can see the markers. Can you talk about the markers on the balloon here?
Yeah, so this is a little unusual compared to most of the angioplasty balloons that we use, where we're used to seeing markers on the proximal and the distal parts of the balloon. In this case, there's a proximal marker, and there are two central markers. So the TE probe is right on top of it right here, but in a minute we'll be able to take a look at that. The central two markers are really to help you determine whether you're perpendicular to the catheter. They're only a couple millimeters apart. If you can see a space in between them, then you feel fairly good that you're perpendicular.
So now I'm across. If you can go to the TE to show what Dr. Goldman is seeing there before I inflate. Can you show the TE, guys? So you can see the balloon right across the septum there. Obviously, fluoroscopically, I'm not as good as knowing this congenital stuff as say, Dr. Grinsteiner, but having Dr. Goldman here gives me the confidence to know I'm well placed. And I'm going to go up very slowly here. And what we're going to look for is the flopping of the septum, right, Dan?
Yeah, so actually what I would do here is pull the T probe up just for a second so that we can see on fluoro what the shape of that's looking like. And you can already tell, if we pull it up just a touch more, this is not looking at all like there's a tunnel to it. So it would form almost kind of the letter S if there was some a long, tight tunnel to it. And this is just flopping away as though it's a secundum ASD.
Is that enough inflation there?
Yeah, I think that's plenty. I think you've shown pretty well that this
Right.
is not going to be a typical long tunnel. So what I would do at this point is deflate that, and then I would go back and have Dr. Goldman look at this under color Doppler as we slowly inflate to see where there's cessation of flow.
Right.
And if I can comment on what you were saying about the imaging here, there are very few, maybe if any, procedures that we do in our heart cath lab that are so critical to have really excellent echocardiographic guidance as this procedure. And my strong recommendation for programs that are starting to do this is to do what they've done here at Mount Sinai, and that's to identify one individual to do all of these cases so that they really not only have a good sense of how this procedure is done,
Now I walked it back.
but also so that the cath lab team and the echo team have a good sense of communication and are able to, to compare this case to previous cases, and I think things move much more smoothly that way. It's much safer.
So now I'm going to go up with him using color, right?
Yeah, and
So
so
I'm going to go back across it now. And
then here's where I do that slow inflation, looking to see cessation of flow, and Dr. Goldman will let us know when we're getting close.
I should be across now, Marty.
Yeah, so you can still
probably
see there's a little, well, that's the catheter artifact.
That's okay.
I'd come
There's
back
still
just
little flow.
Right there, Marty?
Oh, no.
and then probably start inflating there and see what that looks like.
We're going up.
And even come back a little more. You can see that there's
A little more
narrow
of a
and
waist.
near the proximal marker down
Yep,
there. So I'd keep
coming
coming
back.
back. There you go. Right about there is going to be
Yep.
good. And then it looks like we still have color.
No,
going
you still have flow going across. Now you're just beginning to inflate. There you go to inflate. So that's just catheter artifact, but you've closed it now.
Closed now?
And so here what I usually do then is I actually deflate a little, and actually look at the proximal part of there.
Yep.
It looks like you may have a tighter spot there.
Yep.
I would slowly deflate and pull back under fluoro and see if we're getting better central.
Rail the wire hose there?
There you go.
There.
Look at that. Now, in fact, I'd deflate from there and repeat the color again. And this is something that we do quite frequently in our lab. is slowly inflate, see where there's cessation, adjust the balloon, deflate a little bit to see where their shunt recurs, slowly go back up to make sure that we're not oversizing.
So now I'm coming down as Dr. Goldman's putting the color on. Dr. Wiley's fixing the wire. And now I'm going to go back up slowly, Marty.
Still, okay, okay.
Okay, now I'm going to go back up now. Tell me when the color stops.
And you can see there's really a discrete narrowing on this balloon, not a
Just
long
a bit,
segment.
tiny bit. Now
Gone
it's
there?
stopped.
Okay.
Stop. Okay.
And then at this point, I'd go ahead and grab a fluoro image.
I saved it.
And we'll do
measure it.
some measurements by fluoro
Yep.
and by T
Yep.
echo.
Yep.
And our practice has been that as we want to shoot for having the echo and fluoro measurements come within 1 millimeter of each other. And if not, we sometimes repeat these measurements.
Right. So for the audience now, what we're going to do is Dr. Goldman's going to measure the actual defect, as well as we're going to measure the defect using our fluoroscopic measuring tools. And then, so while me and Dr. Grinsteiner go out and measure it, I'm going to have Dr. Wiley walk this out and then hold pressure on the groin. So why don't we go outside and measure
Yeah, sure.
it?
And then the other things that I think will be important, since we're going to be doing this as though this were a secundum ASD, is to make sure that we have adequate atrial septal rims in all of the views, including the retroaortic view.
Right. But this is a... All right.
Yeah, Marty has measured it to something like 0.97. So let's see what's going on with the fluoroscopic measures.
Okay. Jose, can you hang on a second? I'm just
Yep.
I'm gonna measure this. You can walk it out. I'm just gonna measure
Oh,
it.
wait.
So this is good right here,
Yeah,
right?
great. So again, it's a little unusual with these markers, the inside to inside measurements of that longer gap. So the proximal marker to the second marker is 15 millimeters, 15
So
millimeters.
We're gonna go inside
Yep.
the inside.
Uh-huh. Down there. Yep.
Right about there. That's perfect. 15.79.
Yeah, so that looks
All
right.
right, so we're gonna put it as 15. Okay, and now we're gonna calibrate. Okay.
Yep.
It should be waiting here. Great. Now I'm gonna measure. And right about there.
Perfect.
About there, Dan.
And you're almost identical to the
So
measurements
it's
that they got by echo.
9.2, and the echo measured 9.7, so within 0.5.
Perfect, and we would be very happy with those measurements in our lab and would go ahead and make the decision based on that.
So,
How did the rims look on the retroaortic rim?
So this is your aortic rim here. So you have sort of a very small rim. You can see that.
Yeah, so, and this is something we'll discuss also during the lecture, but this, again, adds to the interest and a little bit of the controversial nature of doing this procedure, that the retroaortic rim deficiencies are quite common, and we will proceed, and I think most centers will proceed with closing them, but there is an association with the rare but real late erosions and deficiencies of the retroaortic rim.
and I think that's a great point, because what we have here is we have a protocol in place at Sinai. The patient will get an echo going home before he goes home tomorrow. We'll see me in clinic in 2 weeks, and then at a month we'll get another echo, and then we'll follow them again with echo at 3, 6, and a year. And so far, the patients we've done, have done very well, and I think it's part of the protocol. I think the team-based approach that we have here at Sinai. So now we're going to walk this out. Now we're going to decide on the sheet size and the device size, and I'm going to let Dan just talk about the thought process with that.
Yeah, and here's something where, again, where I think that there is a lot of variability in practice. And in this case, we would try and fairly closely match the measurements that we made, which is kind of 9.5 or slightly more. And we would probably go with a 10 device, 10 millimeter Amplatz or ASO device, atrial septal occluder device. 10, please, that'd be great. Thanks.
So we're going to, while we go grab the 10 French size, I'm going to ask Dr. Goldman and Dr. Grinsteiner to talk about the other rims as well, if this was an ASD, or what are the other things that we need to look for when we're going ahead and placing these things, these devices. Marty, you want to comment on other rims?
So because the device has to overhang a ledge so that it doesn't fall through the hole, so to speak, we want to make sure there's adequate rims, and Dr. Grinstein has really taught us more on this based upon his experience. So in this particular case, you can see the interatrial septum, and I think that that's going to be a bit of a challenge because that's going to be sort of a moving target. And that potentially, unless you stabilize that, I think with the device, can cause a little bit of a problem. A lot of mobility, particularly if your rim by the aorta isn't that robust. This is the aorta where my arrow is pointing over here, and you can see there's a nubbin of tissue, but there's not a wide rim, which is frequently the case with patent foraminal valleys. In the bicaval view over here, again, this is the sort of lipomatous interatrial septum. That may create a little bit of a problem because it's a little thicker in the motion of the interatrial septum. This lipomatous septal area can present a little problem, is that it may separate the occluder edges a little bit more than the other side, so we'll have to take that into account. He has another device. This is his pacemaker wires down here as a pacemaker lead that's going to his right atrial appendage. And Dr. Fisher and I were sort of looking. He has, it's very, very typical in patients with devices, indwelling devices, catheters, particularly AICDs. You see a lot of these fibrinous materials, particularly with some of the PFO. We always raise the issue where that increases the likelihood of an embolic, a paradoxical embolic event because of this fibrinous material.
Right. Marty, thank you. What we're going to do is we're going to focus on the device prep here. If you can bring the camera to where Dr. Wiley and Dr. Grunsteiner are preparing the device. George, welcome. I'm sorry I didn't realize you're back. I'm excited to have you back, obviously. And I just want you to, I think you've seen what we're done so far. We're across. We gave the heparin. We balloon sized, and now we're just about starting on the device prep. So yeah, as they're preparing the device, I'm just going to have Dr. Grunsteiner talk through this while I hold pressure on the groin.
Yeah, can we get, for the benefit of our audience, please get the very specific details of what the sizing of the device is, the neck, the diameter, and how exactly is this going to interplay with the aortic cushion?
Absolutely.
Yeah. I think that's a great point. And maybe what we should do to make things a little bit more clear is grab a couple of the boxes. So Ricky or Liz, if you guys could grab the cribiform box as well as the ASO box, we'll do a little side-by-side comparison here. So
can you show the boxes, guys? Yep.
Yeah. So we'll start off with what we're going to use here. Can you see here the? Okay. So this is the Amplat septal occluder. This is the original device that was created for secundum atrial septal defect closure. You can see here. There's a central core, and when we talk about 10 millimeters in size, that's that central self-centering waist, okay? There are, as Dr. Goldman mentioned, the discs of the device actually extend beyond that. This is the left atrial disc, which is the larger of the two discs, and the right atrial disc is somewhat smaller. In most of these devices, the left atrial disc extends 7 millimeters beyond the central disc in every aspect of the circle, so a total diameter difference of 14.
Right.
Taking a look over here at the cribiform device, and this is actually used for PFOs as an off-label use. This was created for multifenestrated atrial septal defects. But you can notice a couple of distinct differences. One is the central portion of this device is just a hub, basically. It's not meant to occlude the defect. It's meant to have good apposition of the discs.
Right.
And the discs themselves are the same size in this case. So we talk about the size of a device, in this case a 25 device. Each of the discs is 25. So we're not going to go with this because you can see there'd be a lot of mobility with that central hub there. And since this atrial septal aneurysm is allowing for so much mobility and opening and closing of this PFO, I think that there may be some added risk for embolization with this device, and I think the self-centering mechanism will help to fill that out. We can take a look at so once we've decided on the size of the device, in this case a 10 millimeter, we match that up with the size of the delivery system that's needed. In this case, we've chosen a 7 French delivery system.
So I'm going to go ahead and set it up with Dr. Grunsteiner as he talks you through it. Go ahead, Dan.
So they've gone ahead and
can you put a light here, please? 1 second, let's get a light on this thing.
And actually, let's put a. Do you have
We can see very well here, by the way. PK, we can see very well.
Oh, you can see? So,
right
okay, George.
We can see very well.
Okay, George, I'm sorry about that. We're going to flush everything
so
now.
This is the TorqueView system, comes with the device, and it has a 45-degree angle. It's nice and flexible and kink resistant.
that. Yeah,
It
okay,
comes
flush.
also with this delivery cable
Good. Okay.
and the delivery
Flushed.
introducer and a TUI, the long TUI. So what we'll do here in order to, I mean, really kind of the most critical thing in this is trying to debubble the system as best as possible so we don't introduce air to the
Keep
left side of the
flushing.
heart. So we'll give it a quick little flush. And then what we'll do is we'll advance the delivery cable, great,
Right. All the way down.
through this system and then attach the device.
Fantastic. Now this attaching the device is really the fun part of it because it's certainly requires a steady set of hands. So you know and the most important thing here is you see he's not stretching the device. He's not doing anything in terms of to damage the device. And then we're going to go ahead and now attach it.
So there you see again, there's the self-centering portion. That's the 10 millimeters. We have the left atrial disc here and the right atrial disc here. And there's a screw mechanism. It's okay. We're gonna use a different cable
that
there.
happened?
But there's a screw mechanism here on this hub, and it matches up very nicely with the cable that it comes with. It should be very smooth when it goes on. If there's any sticking to it, you should detach it and try again. In general, it's very simple once you have a little bit of practice of screwing this on. I've never had any problem screwing it on except for when I did a live case for TCT years ago, and of course, in a live case, it was difficult to screw on. So we'll see how we do here today under the pressure of the cameras.
So what unfortunately we dropped the cable there, so we're going to get another cable. And then we're going to go ahead and hopefully Dr. Wiley doesn't drop it this time.
It was the fellow that bumped it out of his hands, though.
It had to be the
But
fellow.
honestly, I'm gonna protect Mike because Mike's way in the back, sleepy from last night. So I'm gonna protect Mike. No way Mike did that.
So I don't know if you saw that going, but that really was very easy. And you should be able to just screw this on lightly with one finger. And then what we'll do is I like to actually pull this into the system submerged. And so maybe if we put that at an angle, so can you see that on the camera? Okay?
Can you see it, George?
Yeah, we can see very well.
Okay.
Great. And so different people have different theories. Some people say pull it quickly to expel the air. I tend to pull it a little slowly and give it a tap. You can see bubbles rising as we do that.
Now that's very important. This technique right here is how to get it out. It's very important. Dr. Wiley's been flushing.
And then he's going to take a big flush here, and I've got my finger covering the bottom.
And
So he's flushing air to the top.
And you want to make sure it doesn't hit you in the face. And then as it comes out, you want to close it up.
And then we'll submerge this again.
And you'll flush again.
And we'll flush again down to the bottom, and we'll probably see some air come out again. There you go. There's some bubbles there. Beautiful. And so now we've got a nice bubbleless system. You can see the device is now low profile within the
Beautiful.
introducer. And Dr. Christian's going to put that into the
sheath.
delivery system.
Yep.
Well, we've got to put the delivery system in place.
Yep. Now we're going to have Ray excuse himself here for a second. So what we're going to do is, before I do that, I gave another 1,000 units of heparin. So I want to check an ACT. Mike, can you grab me a syringe? So we're going to check an ACT, and then we're going to go forward with the delivery system. And I think, George, those points right there about the device, and I think the point you made regarding, how to choose the device and what to do are very, very important. I think clearly, flush the arterial sheath, please. Oh, not yet, Jose, hang on. I think also the prep of the device is very tricky in the sense that for the first timer, it's not at all difficult. It's a very user-friendly device. I really think that as long as you work as a team and train like a couple of people to do it right, it really works out well. So now we're going to go with the 7 French, I believe this is right.
Yeah,
7 French introducer sheath in, and now again to show you what's happening in the heart. We've got my implants wire really wound to a T here. I'm just going to straighten it out a little bit and keep it out, like that. I prefer to keep it like that so it doesn't have any redundancy in the left atrium. Again, I'm very lucky to have Dr. Goldman here so I can actually direct it under TE guidance. The whole idea here is going to be to get the dilator across and then to unsheath the dilator and move the sheath into the upper pulmonary vein here. I think this is where you need 2 hands. It's going very smooth right now, and I'm going to have Dr. Goldman, I'm going to let him know when I cross that septum.
I think it's an important point. Most of the time we advocate for detaching the dilator on the right side of the heart in order, if there are any air bubbles in there, in order to introduce it on the right side rather than the left. But I agree with you. In the case of a PFO or in the case of a fenestrated defect, I like to have the dilator go across so that you're not catching any of the septum with the large orifice of the sheath.
Now, can you show the TE so we can see whether I'm across, Marty?
Again, looks like you're across there. I'm following up to the left upper pulmonary vein there.
Great. So I'm almost there. So now I'm going to detach the dilator. and I'm going to send the sheath all the way up. And this is where I get nervous, and Dan's always told me not to worry about entering the left upper pulmonary vein. And I'm going to try to just go as far as it allows me, like right about there or a little further.
I'd say if you're going nice and smooth, I'd even advance it beyond that.
So-
and we, we'll do this in 5-6 kilogram babies,
Right.
and not have too much concern. So I
Again,
think you're okay.
being an adult guy, I'm a little nervous. I'm right about there. And I know, again, I've got Dr. Goldman here to tell me that I'm okay. So the key here is you can't allow it to.
Can you just see his hands here? Because this is another thing I think is really important.
So go ahead.
So I'm sorry to interrupt,
Go ahead.
but one of the things I would say is we have an intubated patient who's getting positive pressure breaths here, and so
you're
they're
pretty-
doing a nice, careful job of making sure no bubbles enter the system. But odds are, once this comes out, it's going to bleed back pretty well.
It did.
If this is a spontaneously breathing patient with being done with ice and they're taking breaths at this point, there's no hemostasis valve on the back of this, and they can suck air in. And what I do at this point is I would have this submerged under a big tub of saline. I don't do it in general anesthesia cases with, I do exactly what you're doing.
Right.
But if this patient were spontaneously breathing at this point, I would have this submerged. Sorry, go ahead.
Sure. So that's from our carotid experience where we use a 20 cc syringe to go ahead and remove it. So now it's bleeding back. So I'm going to have Ray just hold. Actually, you know what? Just put your hand on that sheet there. And what we're going to do is we're going to attach the piece right here, Dan, and then we're going to advance this. I'm going to make sure it's nice and tight, and it is. Now I'm just going to advance this forward. Now, Dr. Grunstein has been here many times, so I'm just going to teach you what he taught me, which is that as this device comes up, I want to make sure that there's no air in front of this device. Now, Dan, can you just comment on that one?
Yeah. So I do a couple of things just to check the device once I see it come up on the screen. One is, and I know this is bizarre sounding, and it apparently was just a single case, but where the operators accidentally unscrewed the device at this point. So what I usually do at this point is now that I see it, I pull the cable back. Device comes back with it, and so we know we're still attached.
Okay.
And then also I just do a quick scan visually in front of the device to the tip to see if I see any hyperlucencies that could suggest air. I don't see anything. I think you guys did a great job of keeping it a bubbleless system.
So far, God willing, right? And then now we're going to go forward with this. And again, now I've got Dr. Goldman to assist me to let me know where we are as far as the device is concerned. I should be across now, Marty.
I see the introducer. I don't see the device yet.
You know? Okay.
It may be a little tricky to see inside of the sheath.
We
but-
should be
Right,
across.
so I'm
Yeah.
saying I see the sheath,
So
and
I'm-
I see the sheath all the way into the left upper pulmonary vein there.
Great, and he's advanced it up towards the left upper pulmonary vein now, and
So now
we'll
I'm gonna
probably park
unsheath.
that right
There's
where
the
that marker
yeah.
band is.
which is the device up there?
Yeah, all the way up to the marker band. I think you'll be fine.
All right. So now we're in the pulmonary vein.
Right, you're just touching into the left upper pulmonary vein.
Great. So now I'm going to pull the whole system out of the pulmonary vein.
Still in.
Yep. Now this is when TE guidance is extremely important here, because I don't want to obviously deploy the device in the pulmonary vein. And usually you'll see a little rocking like that. Is that okay now?
I would come back even further because you're still
You're
beyond the
still-
heart border.
You're still
and,
in the.
and,
at
and
the-
typically you engage that left upper pulmonary vein as you did when you went in, kind of at the left part of the spinal border.
Now it's
And so
rocking.
I'd still probably come back just a bit more because I think you're still outside the border. And what you'll typically see is that the whole system will kind of drop a little bit as it enters the left atrium and move a little bit more with
There
it.
you
Start
go.
to see it move a little bit more with the body. And then now under echo, Dr. Goldman will be able to tell us whether he thinks we're all the way out. But I think the device position is probably good. The sheath may still be slightly in the left.
Right, the
pulmonary
sheath is still up in the vein.
Yeah. There you go. Now, see how the whole system kind of dropped?
Yep.
And now you're really moving with the heart. My guess is we're out of the pulmonary vein. Does that look like it on echo?
So you're out of the pulmonary vein. You're actually pointed towards into the appendage now.
Perfect.
Okay. So now I need to see. So I'm going to go a little LAO just to try to get it off the TE probe or RAO. Nope, I can't see.
I'd
So
go.
I'm going to move the probe up.
No, actually, I'll just go LAO. You stay there, Marty. There
So
you go.
actually, the device is in the appendage. I mean, you have the tip of it in the appendage.
Yeah. And that's okay. I mean, what you don't want is to advance anything into the appendage. But at this point, the technique that Dr. Krishnan will show you is you really pin the cable
Yep.
and expose the device. And as
that-
long as you're not advancing the device, you shouldn't damage the appendage at all.
So Marty, am I still in the appendage?
You're. Let me just check the appendage. No. You're
At
out.
this point, if you advance the device, it would come out as a sharp point,
You're
and you
not
really
in
want to
the
avoid
appendage.
doing that.
holding the device and pulling back the sheath.
Holding
So
the
now
cable,
you're beginning
exactly,
to- now you're
and then
beginning to
pulling back the
expand.
sheath so that it exposes the device. And then the nitinol will want to reshape its original
So here's-
conformation and will pull back
Look,
away from
You can
the
see on the
appendage.
TE very nicely.
Maybe going back to
You
straight
can
AP now might
You can
help.
go to LAO maybe or AP.
So you can see the TE, you're sort of right at the left atrial edge of the PFO.
And one of the things that can help a little bit here in terms of getting a little bit more perpendicular to the septum is to give the entire system a clockwise rotation. In the cases where there really is a large secundum defect with a deficient retroaortic rim, that's a really important maneuver to make before you pull back.
So I just clocked it down, Marty. Can I see the regular view here?
So you're still perpendicular.
I think if you come a little bit more clockwise and pull back a bit, I think it'll start to look really nice.
That's,
There you go.
You're doing better there.
That's nice. And then I'd pull back towards the septum there. I think you're going to orient very nicely.
And that's good right there. I'm going to start deploying.
And come back a little more towards the septum. So you really engage this floppy septum a little bit. And then I think once you have the self-centering waist out, this is going to orient beautifully.
Now I'm going to start deploying. I'm good with that. You guys?
Pull back a little more tension on. Because that floppy septum is kind of moving away.
So it's
from the-
very important now to identify that the disc that you see is one of the discs, is a distal disc, the left atrial disc, and we're
Correct.
sitting on that side,
Much better.
That's
and
nice.
that has no way of stabilizing. But we have to make sure that we're through to the right side when the right atrium disc is deployed, which happens slowly right now, so that the septum will be in between the two discs, as opposed to both discs being on the same side of the septum, which is not going to be good.
Absolutely.
And you see on the TE right now that the septum indeed is sandwiched between the two discs.
and that's
I
an
think
incredibly
as you
important
pull
point.
back, you'll probably position better, because right now you're still 70-degree perpendicular.
Okay, this is a great example of one of the new modifications. So you can see here that there's quite a lot of tension on this device, and it's distorting the way the device looks. And it's not until you release this device that you're going to actually see how it's going to lie against the septum. St. Jude has just released a new product. I've only gotten a chance to use it twice, and we'll take a look at some pictures during the lecture, where there's actually a soft inner cable inside, a soft inner core inside of this cable that you can now advance the device out and take the tension off. But here, as was being said in the moderation, it's really important to make sure that you have tissue in between all aspects of this
Which
device.
we see it, although we still see it mobile, exactly
Right.
for the reasons that were outlined right now. And if we release a little bit more, which PK has, you can see on the fluoro, the discs, the right atrial disc is more flat now. The more flat the right atrial disc is shown, the more deployed the device is, the more fully deployed the device is, and therefore the better alignment it may actually acquire, which
And
we
it-
may or may not see. But
It'll be very important to see this, exactly what you described, in multiple views. Because you can have some views where you think that you've got the tissue nicely between the rims, yet some edges of the device where it's not fully captured.
Now, George, what I did was I reduced the tension on the right atrial side of it,
Yeah.
just to let it settle. And then I want to see, I'm lucky here. I've got Dr. Goldman, we've got everybody here, Dr. Grinstetter, yourself, Wiley, and I think we make a decision here on how to release it. I tend to agree with Dan that I think once we release it, it'll settle back to a nice
Yeah.
position. But I just want to make sure that there's tissue everywhere, and that's where having Dr. Goldman's expertise really helps you.
I mean,
What do you
I
think,
agree. Right
I think
now,
it's looking nice.
perpendicular.
You still think it's perpendicular, Marty?
Yeah, I mean, you can look at the.
well, it is perpendicular, Marty, but can we go to another view to make sure that the tissue is in between the discs?
You have the tissue. You can see the intestinal septum as it over. It's
Yeah,
sort of.
yeah, we see it in both views, exactly.
Yes,
We see it in both views, in between I would say it looks like
so-
a clause there.
So what I would predict at this point is, I mean, first of all, Dr. Goldman's going to do a complete assessment, looking at rim tissue in all aspects of the device, and also looking for additional defects which may have popped open now too, which is important. Also making sure the device is not interfering with the mitral valve, and I think we're far from that, or the pulmonary veins. But my prediction is that once this is released and that tension is off, this will no longer be perpendicular. Right now it's being tented up because of the torque that this stiff cable is creating. And that'll be released, and it'll lie very nice and low profile against the septum. But what some people are uncomfortable with is that you're going to see a lot of movement to this device because of this large atrial septal aneurysm. I don't think that that's a problem. I actually don't think there's much you can do about that unless you want to go and do a transseptal puncture and then put a cribiform device through, which I don't think is worth the added risk in this case. But you'll see a nice device that's parallel to the septum, but that's moving with the septal aneurysm. This is going to be a nice result, I think, as long as we're sure that the tissue's in between all aspects of the device and we don't have any other defects that have popped open.
Yep, and I think that's where I'm going to leave it up to Marty now, because we're pretty much at the final stages. As long as we have tissue, I think everybody's comfortable with the way the device looks, and I think everybody's in agreement that the tenting is because of the tension. So as long as Marty says to us that we got tissue everywhere, and it looks pretty good, I think we're going to release it.
I think you set that up perfectly, too, because this is a great procedure for us as interventionalists because we get to do a lot of fun stuff. And if anything goes wrong, we can say, well, that's because the echocardiographer didn't show us what we need to know. They're the one that said release it.
Well, I didn't mean to say it like that, but Marty knows better. He knows me well.
I know PK has my back.
And actually, that is a gorgeous image. I mean, look at that. You can see beautifully how the inferior part of that septum kind of drapes over the inferior aspect of the right atrial disc, and you can see it all the way extending to the central waist of the device. And just a couple frames ago, we saw the same thing on the superior edge. Really nice picture.
And you know, in honesty, I'm spoiled. I mean, we are actually at Sinai. We've got, you know, Dr. Goldman here in cardiology, Dr. Fisher in anesthesiology. Give us just incredible images when we need them. And, you know, it gives you a lot of confidence in doing this. And I think part of showing you guys this multidisciplinary effort is showing you the importance of having good imaging and not just to dive in as an interventionalist or a pediatric guy or whatever, whoever's watching and doing these cases, but being certain, doing a good selection, having the right people in place, having a team together. Let me tell you a little about when we started. Dr. Grinsteiner came in, we did 3 or 4 cases twice, and then we had a lecture with the echo team, which Dr. Goldman led, and then, you know, went over all the different things to look at so that we were very, very clear on how to do this as a team. And I think it's a model that's worked well for us, and I think, you know, as you know, you're not going to do a ton of these. It's not going to be a 20 case a month kind of procedure, but yet at the same time, the ones you do, you want to affect the patient positively. And I think having that team in place really helps us to affect the team, affect the patient.
I cannot agree more with that. I think that this is a case where the actual technical aspects for the interventional operator are pretty simple. The mechanics of this device are pretty straightforward. This is far and away easier than a lot of the other things that you do here in the lab. The critical things here are really the decision making, the understanding of the anatomy, and having a team where everyone is double checking each other. Mm-hmm. And I think that the model that you guys set up and your approach to it really should serve as an example. And is the way I'm encouraging other programs, having seen you guys do this, I'm encouraging other programs to do it the same way.
So Marty, we wait for you.
No, we're fine.
So, PK, can you do the final pre-release test as well once we see the echo image to move it?
Absolutely. I just
want
want
to
make
sure.
sure.
I think we're good with echo.
Marty, what do you think?
The echo is
I
very
think we're
good.
fine. You know, you have that. You've actually, what's good is
Yeah,
that
would
you
advance the
reduced some of the intratracheal septal motion by keeping it a little bit taut, which I think is good. So the angle, I think, once you release the right atrial side, I think it'll come back into position.
Now, I'm just going to go ahead and do certain things again. The first thing is we're going to move the sheath closer to the release point, which is going to prevent this, the actual, I guess, the stiff rod from damaging the atrium while we release it, because you'll see it's going to move. Then I'm going to let Dr. Wiley do the release here. So we're going to do a counterclock mechanism, I believe, since we clocked to put it on.
Yeah.
And so now Dr. Wiley's going to do the counterclock as I hold the sheath close, and he's counterclocking now. And you'll see he'll just pop right out. And
it always takes longer than you expect. It's a good 6 or 7 full revolutions.
Yep.
There you go.
There it is. And I'm just going to pull it away.
And already you've seen a pretty significant change in the orientation. And look at the difference on echo now.
Yeah, it looks exactly aligned as expected and as described by all of you. And it's very nicely, the septum is very nicely sandwiched. Still a little bit of some mobility, but not an aneurysm anymore.
Yeah, George, that's a great point you made. The mobility is not, we're not going to get rid of that mobility. That mobility part of it is going to remain unless we do a transeptal puncture, and we know that that's not necessary in these particular types of cases. Number two, now we're going to have Dr. Goldman, very importantly, do some parameters. And I'm going to let just Marty talk about his post-appointment checks, so this way all of you who are watching can, do the same things that we do here at Sinai. Marty, you just want to focus
I'm
on...
going to do the same
And
thing.
Dr. Wiley, what do you think about the feeling you had during turning the knob and all that? Was that smooth? Anything very particular before we go ahead with the final echo comments?
Actually, it was very smooth. I did approximately 6 counterclockwise turns, and immediately it released.
Beautiful.
Quite well.
Marty, yourself?
Yeah, this is 87 degrees, but this is the device sort of deployed nicely. This is next to the aorta, and you can see it's not pinching the aorta at all. There was enough of a rim, and PK deployed it nicely so that you're off of the aorta. The interatrial septum is still quite mobile, but the defect itself is occluded. When you put color on, what I like to do is lower the scale even to pick up anything that could be within the device. It really looks pretty good. It's the Nyquist, lower the Nyquist it's called. Looks pretty good at this angle. If you hit it with a biplane, just looking at it, on the right-hand side you can see how flush it is against the interatrial septum. There's no evidence of any residual flow across it. Again, it's mobile. I don't think I can do anything about that because the interatrial septum was long. So I'm just looking at different angles. I had looked at the mitral valve before. Again, this is the angle up against the aorta, which is nice. 3D again showing you the rocking of it. If we look at the mitral valve over here, there was minimal mitral regurg to begin with. Again, there's none. Looking at I'll take a look at the tricuspid valve as well, which is a little bit lower down in the screen.
The question was a clue that we're not that.
So the tricuspid valve is way down here, far off from the device. So this is a pretty good angle where you can see the device interatrial septum still mobile because that wasn't affected by the device. And the aortic side of it is quite flush. Again, no flow even with the lower Nyquist. So really, I think well deployed.
So you saw all the parameters. I just want to make a little comment, ask Dr. Grunsteiner. Dan, as far as antiplatelet agents, obviously this guy has had a CVA. He's recovered, thank God, because of thrombolytics. He has no coronary disease. As far as the algorithm that you suggest for all of us out there to do this, what do you suggest in terms of what agent, how long, and what are the parameters we watch for?
There's a lot of variability in practice, both between pediatric and adult interventional cases, as well as from adult interventionalist to adult interventionalist and neurologist to neurologist. Even in the RESPECT study, there was quite a wide range, and it was left at the discretion of the neurologist. One thing I would say about it is there really is no data that I know of to suggest that one strategy is better than the other. What we do in pediatrics is we do 6 months of aspirin, and then as long as there's complete resolution of shunting, at that point we discontinue it. Our adult colleagues at our institution for the first 3 months do aspirin and Plavix, and then do an additional full 6 months of aspirin. But there's really quite a wide range. Some neurologists advocate for use of warfarin alone. Some do combination therapy. I think the most important thing is that you are using something antiplatelet and that you're screening these patients occasionally. I don't know of any anecdotal or case report evidence that there's any significant risk for thrombus formation on these devices.
And arbitrarily here at Sinai, we've chosen to give 6 months of aspirin and Plavix, and then once as long as there's no residual shunting at 6 months, we go ahead and then stop the Plavix and put them on aspirin, as long as there's no other reason for them to have clopidogrel, not necessarily Plavix, clopidogrel. So I think we're done here. I think, like I told you, the follow-up for the patient I really thank Dr. Fisher. Thank you so much for doing this. I know he came in and took care of this for us. Dr. Goldman, thank you. And Dr. Grunsteiner, thank you so much. And George, thank you again for this. And I think we're going to sign off from the cath lab. Thank you. And I just want to, I'm sorry, I forgot that George had to go to another case, but I just wanted to say, tell everybody that we'll start again in January. Wish all of you a merry or happy holidays, Christmas, Hanukkah, whatever it may be, and a very, very happy new year. And we're excited for this. This completes pretty much our first year of this live peripheral intervention course. And hopefully next year we will bring you as many good cases and more importantly different cases that are really not so much looking at the technical aspect of it, but more the actual approach to the patient, looking at the data, and what is the appropriate way to handle these very complex patients. And I think it's our real goal here is to teach that, and if we can get that across to you, I think we would have succeeded. Again, I thank you and have a happy holidays and a happy new year. Thank you.